Next topic, also very much important, that CT, role of CT in the cardiology, both in chronic stable angina and in ACS is very much important. I'll request Dr. Rajesh Kannan to tell this role of CT in cardiology.
Thank you once again. Good evening. So after hearing for nearly a couple of hours regarding cardiac MR, so we'll move on to the role of cardiac CT. So we have come a long way in terms of coronary angiography, where few decades back angiography was done using the roller film to the CT coronary angiography, where even without entering into the aorta, you can able to get such a beautiful coronary arteries. And if you look at the, I'll quickly run through the different indications which you can go through in the literature. So the important areas where cardiac CT will be useful is one is on not only the looking at the coronary arteries, we can look at the heart as a whole. Now we can look at the aorta as well as the pulmonary arteries. I'm not going to discuss further about the pulmonary embolism, because the CT angio is currently the gold standard for the diagnosis of pulmonary embolism. Then we'll discuss about the coronary arteries and finally about the different aortic pathologies. And if you look at the different guidelines, and many of the guidelines now shown that the importance of cardiac CT in the evaluation of patients with chest pain. So we'll look at the different indications and the different types of cardiac CTs. The first thing is the calcium scoring, so which is a plain scan, and which is a very well established method in the risk assessment. And this is a case where you can see that extensive coronary calcium involving all three vessels with a value of more than 1,800, which suggests that patient is in a high risk. So when you are looking at the calcium score that everyone knows, you can get a lot more information, not just the Augustin score or the values. See, if you look at the two different cases here where the volume score was nearly equal, the overall the number of calcium, we can also look at how dense it is. Here called the density factor, which also we can get it, the number we can get it when we are doing the calcium scoring. In this case, we can see that the density factor was low as compared to the high density in this case. So what is the importance is, if the patient is having the, even though high volume, if the density is very low, these people are more prone to develop a high risk of cardiovascular disease, as shown in a MESA study. So not only the score, we can also look at the density factor, whether it is a low density, which is much more riskier than the high density. Coming to the CT coronary angio, the most important thing, and so many studies has proven that it has more than 99% negative predictive value. So if you can able to see a segment which is clearly well opacified on a CT, then now it's very, very unlikely that that area going to have a significant stenosis. So, and if you can able to demonstrate a good vessel like this, and both the multiplanar view, VRT, or the tree view, what we call it as, and if any segment is absolutely normal, then that suggests that it has a very high negative predictive value. This is an interesting case. It's a doctor where now he has recurrent chest pain, and he don't want to do a cath angio. And when we did a CT, his calcium scoring was very, very low, but still we went ahead with the CT angio, which showed a very, very critical stenosis at the circumflex artery. And patient was planned for an elective revascularization, but within a few days he landed up in the emergency department with an acute MI, where this artery was completely occluded. So we can able to assess the coronary artery very well when the patient is not willing for a cath. And this is a case where a cath was done where they couldn't able to cannulate the left main, so CT was done, which clearly showed the left main coronary artery critical stenosis. This is one of the major problem when you are doing that. Sometimes it can dissect and can end up in a catastrophe. This is such a non-invasive technique where we can able to clearly demonstrate the left main coronary osteal pathologies, and this patient directly went to cath, went to CABG after the CT based on the CT finding. And you can also now show the different pathologies. This is a case now showing the left main trifurcation lesions and its extent. And what is important is even after doing a cath, sometimes CT can be helpful, especially in the case of LAD occlusion, and where you are just seeing the stump, and if you want to know the distal to the occlusion, what is happening, how much is the calcium, is it in a highly calcified area, and how far is the length of the occlusion, and if you want to plan the intervention, then CT may be useful. And also, if you look at the compare with the cath, the CT angio, you can see that how accurately it shows the lesion, the culprit lesion. Also, again, now we can see that it not only shows the area of stenosis, it also assesses the what is causing the stenosis. It gives the morphology about the underlying plaque also. So we know that what is a vulnerable plaque, and now we can use the CT scan not only to assess the lumen, we can also assess the vulnerable plaque. There are few features which favor the vulnerable plaque, include a spotty calcification, low attenuation plaque due to the fatty substance within the plaque, positive remodeling, and the napkin ring sign. So this is again showing a vulnerable plaque. So it's not only the lumen is important, we can also look at the plaque. And also now there are many studies shows that peri-plaque, the inflammatory changes which can also be picked up on a CT. And this is the Romicare 2 trial, so that the high-risk plaque detected on a coronary CT predict the acute coronary syndrome, which is independent of the stenosis in an acute chest pain. Coming to the coronary anomalies, yes, CT is the investigation of choice when you want to look at the exact the course of the coronary arteries, and when we are looking at the coronary anomalies, it can be due to the anomalies of the origin, it can be anomaly at the course or the anomalies of the termination. And here we can differentiate between a malignant course, which is between the running between the pulmonary artery and the aorta, versus the benign courses. And in this case, we can see that it's a malignant coronary artery where there is a tight stenosis as it runs between the aorta and the pulmonary artery. We can also assess the intramural course of the coronary, the proximal coronary arteries. This is a case of left main coronary artery to the right ventricular fistula. Aberrant coronary arteries can be assessed. High origin of coronary artery sometimes very difficult to enter by looking only at the level of the sinuses. The case of an Alcapa, aberrant left coronary artery, where you can see that the right coronary artery is grossly dilated, hypertrophied, and the left main coronary artery is arising from the pulmonary artery. Coming to the post-intervention assessment, the CT as compared to the native vessel, post-stenting, it will be useful, but as compared to the native vessel, when there is a dense stent, or if the stent is in a smaller vessel, then may be a problem. But if the stent is not having a thinner stent, and if it is in the proximal vessels, then we can assess the instant stenosis even with an CT. Here you can see that there is a instant stenosis, which is confirmed on a cath. Again, another case of LAD instant stenosis, different types of occlusion. And just by looking at the distal vessel, you cannot able to, you won't be able to say that whether the stent is patent or not. You have to look at the lumen inside the stent. Coming to the CABG, to assess the graft, CT angio is very good. Now looking at the different grafts, the Lima graft and the SVG grafts. Here you can nicely show both the proximal anastomosis and the distal anastomosis, nicely patent grafts. And this is a case where we published way back in 2007. Post-EAPG patient developed acute chest pain, and CT clearly showed an acute thrombus in one of the graft. Here we can see that after the thrombolysis, it has completely disappeared. The thrombus disappeared, and this is a follow-up. We can see that this is the thrombus. This is after thrombolysis, showing a normal pattern graft. So to assess the graft patency, CT is very good. But to assess the native vessels in a post-EAPG sometimes may be tricky, especially if there is a severe coronary calcifications. The other newer modality include the CT FFR, which is similar to the invasive FFR, and where we can get the value of the FFR. Here we can see that the moderate stenosis with a FFR of 0.95 indicating that stenosis is not significant, whereas in this case here we can see that the CT FFR of 0.76. The only problem is this is not widely available in India. So only now one company is currently doing that. So except for the availability, it's a very good the tool which is non-invasively measuring the CT FFR. We can also do a perfusion study, even though MRI gives a much better resolution. Even using a CT, we can do a CT perfusion scan. We can do the stress perfusion under the rest perfusion. Coming to the aortic pathology, it's not only the coronary arteries. It has a major role in the different aortic pathologies, including the acute aortic syndromes in aortic dissection, intramural hematoma, or a penetrating ulcer or a rupture. And where CT can give you the information regarding not only the dissection flap, it shows where is the entry points. So here we can see that the entry points and the exact extent, whether it is extending into the ascending aorta or into the coronary arteries, and it's the different extent into even the abdominal vessels. Here in this case, it's a type B aortic dissection where the entry tier was more distal, which has been treated with the endovascular stenting. And this patient presents with an acute chest pain where where the coronaries were normal, and when we did a CT, it showed a intramural hematoma. And patient was kept in an ICU. After few days, he developed increasing in the chest pain. And the follow-up CT, there was the contrast leak is happening into the lesion, which suggests that it's going into the dissection. Here you can see that there is a intramural blood pool contrast is happening with the increase in the pleural effusion. And this patient is treated successfully with the endovascular aortic stenting. Whereas this is another case, we again presents with the acute chest pain and the CT showed intramural hematoma, but over a period of time we can see that it is spontaneously resolved. So which suggests that not all intramural hematoma needs treatment. So now we can do a follow-up on a control if the patient is stable enough, especially in a type B aortic dissection where it's not involving the ascending aorta. Now we can do a follow-up scan and we can confirm that patient is stabilizing. And in the current era, I don't think anyone is doing a major endovascular aortic intervention without doing a CT, whether it is a TAVI or aneurysm repair or repair of the dissection. So where a CT plays a very, very major role. So there are limitations. It's not that CT all good. Still, even in the current era of the so-called 256 slice CT or a 320 slice CT, the heavily calcified vessel, then still we have a problem due to the blooming. Small vessels which are less than 2 mm may be difficult to assess. Instant restenosis in a small arteries can be a problem, as well as if the patient is having a severe cardiac or a respiratory disease with a very poor breath hold or with the cardiac arrhythmias, sometimes can be an issue. So here comes one of the newer latest technology called the photon counting CT, which now has a lot of promise in assessing some of the small vessels, as well as looking into the stent. This is going to become a game changer in near future, where this uses a completely different method of post-processing. So that is going to be a lot more helpful when you are looking at the coronary angios. So in conclude, can say that there is a huge gap between the number of cath labs which is available in the country versus the cardiac imaging centers, and we should not say that it is not available. If you can push your radiologist to attend some of our conferences, like IAC conferences, where they can easily learn these stuffs. And currently there are a lot of centers have 1.5 Tesla MRI and the 64 slice scanner. It's now widely available. Only thing that we need an expertise. So that it will be possible with the organizing conferences like this. And I can say that both cardiac CT and cardiac MRI plays a very, very major role in daily cardiac practice. Thank you.
Thank you, Rajesh, for excellent discussion. But I will have one question, that suppose a patient having severe chest pain in the emergency room and ECG is normal, but this is typical angina. So, except that you told that CT signs of low attenuation plaque, positive remodeling, and spotty calcification, napkin, besides all the features, if I refer the CT, can I safely discharge this patient, or I have to keep the patient for observation?
Yeah, so this is one area there are a lot of studies are happening now in the emergency department, and if we can do a CT where if we can clearly able to demonstrate that the lumen is normal and there is no high risk plaques, I think the studies have shown that the admission rate and the hospitalization rates are the days are very, very less. So most of the patients can be discharged, and especially if the high sensitive troponin also is normal.
Thank you, Dr. Kannan. Actually, your second name reminds me one of our very famous footballer over here. He used to play for the big clubs here and an extremely good footballer. And that skill you have shown during your lecture. You are an extremely good talker. Now, I have a comment and a question. And the comment is regarding calcium scoring. That is not being done separately in our city. They are combining it with imaging. And at times they are giving report that the high calcium score, we cannot do a proper CT scan like that. So how can we promote them to do a CT scoring separately so that we can write CT score or CT imaging depending upon the situation? I want to have your suggestion and if possible a consensus from this home. Another is regarding the CT guided FFR. I am myself in search of where to get it done in India. And I have been told that Breach Candy is doing it. Are you sure about that?
I don't think, anyway, they will be sending the images to the heart flow team. And anyway, we are not doing the post-processing here. Whatever, we can do the scan here and we can upload the data to the heart flow team, and they will do the post-processing and they will send it back. So we don't have an in-house post-processing tool. Still, it is the heart flow team now which is doing that.
If I am asking you that if
Yes.
we send CDs to you taken from our own machines, good quality, maybe 128 slice, and then I ask you to interpret whether the FFR guided CT can be done or not, can you do it in your center?
Yeah, see, the only problem is the cost. I think its cost is around, will come to at least 15,000-20,000 if you are converting to the Indian currency.
So separate,
Yeah,
over and above the
because it is
whatever.
done, you have to send the data to the heart flow team, and they only interpret and send us. So only if you have some sort of a tie-up and if we can do regularly basis, then they may be come up with the lower cost.
Thank you so much.
Yeah.
Dr. Kumar?
And coming regarding the calcium scoring, yes. So I think as a team of cardiologists here, we have to now take a decision. In our center, we have a separate calcium scoring as a separate order, where people will be doing only the calcium score, and we'll now do as a part of the risk assessment. And if the calcium scoring is very low and no other risk factors, then we may not do the CT.
What is the average cost of just a EBCT?
Only CT calcium scoring costs 4,700 in our center.
Any questions from the audience? I mean, cardiac CT at least has is more frequently being done in the city, so I'm sure somebody would be having some questions. Any questions?
Is there someone who is doing both CT and writing, CAG himself, and writing CT at times? What I have seen that interventional cardiologists are prone to write the conventional CAG rather than writing CT angio. I myself, of course, often write CT angio, though I am doing CAG also. So, is there anyone? Dr. Nath?
Yeah, that cardiologists write CAG, traditional, and others do not write. I think there are proper indications where we need to do a CT angio rather than a traditional coronary angiography. Like
Do
if
you
we
want
do not,
to take home message from Dr. Kannan regarding this?
yeah,
That
there are already
when to do a
guidelines
CT
there.
and when to go for a conventional CAG, do you want any guideline?
If our index of suspicion of a obstructive coronary artery disease is high, it is better to do a regular coronary angio.
Sir,
It
your
has got a
comment.
strong negative predictive value. So where we are suspecting that the obstructive coronary artery disease is unlikely in a particular group patient,
Okay, that is your
CT
gross,
angio is
that
good
is
enough.
your gross opinion.
You have to make a distinction between acute and chronic coronary syndromes. That's the basic thing, okay? So acute coronary syndromes,
Yes.
invasive angiogram remains the mainstay and probably
Yes.
the only choice. In majority of the cases, except where troponins are equivocal, pain is not very typical, you can still do a CT angio to rule out ACS. Other than that,
So-
invasive angiogram. But chronic coronary syndrome, in
Yes.
fact, in the ischemia trial, CT angiogram was the first test to rule out left main or left main equivalents. I mean, they were ruled out. So
Yes, sir.
for risk stratification itself, in chronic coronary syndromes, CT angiogram is most of the time
Yes.
a very good first option.
Yes.
Yes, I agree with Dr. Kumar and Dr. Kannan. I believe that in future that the CT angiography will replace the routine coronary angiography. Unless and until patient is having that acute coronary syndrome, that is probably that CT angiography entirely replace that.
Yeah, so
routine
for example,
coronary angiography.
currently for pulmonary embolism, nobody is doing invasive
Yes.
coronary.
Because
invasive
we
angiogram.
interventional
CT
cardiologists are much more busy with that complex coronary than other structural heart disease, so there is probably less time to do the routine coronary angiography.
Yes.
Now,
Other
as in
than-
case of echo, how much important the man behind the machine is? Whether the machine is more important or the man behind the machine is more important, both are important.
Coming to the CT, as compared to the MR, the learning period is very short. Okay, so if you have a good system and if you clearly show the vessel, now you don't need much experience. Now you can easily interpret that very easily. As compared to the cardiac MR, where you need a little more expertise now for both doing and interpreting. So if you want to say that if you have a very good system, then it's very easy to learn.
So thank you, Dr.
Thank you,
Rajesh.
thank you.
And wonderful lecture again, and thanks again for coming all the way and sparing time for this conference. We look forward to more interactions in future. So we will close the session here on behalf of my senior co-chairs, Professor S.C. Mondol, Professor Das Vishwas,